Learning objectives. Upon completion of this activity, participants will be able to define levels of sedation, discuss the Joint Commission guidelines for sedation, identify critical elements of the patient preoperative assessment, list the 4 Malampati classification for airway assessment, describe the various oxygen delivery systems and airway adjuncts, discuss the pharmacology of common moderate sedation and reversal agents, identify potential complications and appropriate treatment, discuss pre- and post-operative techniques in suggestibility and semantics.
Good morning. All right, you've all shown up here because we're going to talk about moderate sedation, procedural sedation, and how you're using it at your hospitals and in your areas of your expertise where you've been doing sedation or want to do sedation. So we're going to talk about that a little bit. Now, in our little kind of warm-up as we were talking before we got started, I did find this out, that most of you are pretty well in line with what's going on in sedation. You've got a real good outline of what you're doing and what's going on. However, we do know that one of you's not really done any, so you're kind of a blank page as to where things are, okay? So you are going to end up here, at least, minimum. But the rest of you, some of you have already got yourself in a position, you've got it all together. You know what you're doing, you've studied. Those of you that are at the outline, by the time you're done, you'll have everything you need to move from the outline stage up to having it all together so you can go back and be the preceptors that you talked about being when we got started. So that's just kind of how we want to do. I'm sorry, Vicki?
Where do you buy that?
Oh, you can talk to Lena later. She'll take care of you. That's what she does. All right, so we're going to talk about a number of things today, and some of those things we're going to talk about is basically legal and ethical issues that are involved in doing sedation. What some states say you can do and what some states say you can't do. You had on your desk these papers that basically say what your Board of Nursing or your legislation within your state says that you can do, what drugs you can give, except those of you from Tennessee. It doesn't have Tennessee does not have a policy. Now, when I first started doing this back in the early 2000, when I started doing it then, Tennessee did have a statement from the Board of Nursing, not a law or anything. It was just a position statement about using anesthesia-listed drugs. They do not have that up anymore. So I know that they had a little thing between them and Vanderbilt about Vanderbilt wanted to give some medications, especially in pediatrics. So they may have taken it down, but I know it's not been up for a while. These state regulations, we update them totally in a year. We put them out every month. We'll go through and check some and see if they've made any changes. Some of those states haven't made a change since 1998, some of them 2004. I have a couple, it's like 1992 when this all got started. So those are the things we're looking at from that legal side of what you can do and what you can't do. I like to make this interactive, so if you've got questions as we go through, I'm happy to take them. We'll discuss them. I would like to have more discussion because I think you can learn from each other, and this will get some of you that just would like to know, what do you do in your state? What do you do in your hospital? What do you do in your area? And those are some of the things that we want to cover as we go through this. We're going to hit a lot, about 10 modules, 11 modules, and within these modules, each is going to go from everything from how do you do your assessment, what has to be done. We're going to spend a lot of time on the accreditation processes. How many of you are Joint Commission? How many of you are AAAHC? There's 2 others out there. There's the DNV, and then there's one I can't remember. I'll show it to you when we get there. It's the HEPBAC or something like that. But those are the things that we'll be looking at in order to let you know where you're at, what you're doing. Now, this is not, at this time, a national certification. This is a certification through our program and accepted by the American Association of Moderate Sedation Nurses. It's not at this time accepted by the American Nurse Credentialing Center, the ANCC. And a lot of that is because there's a lot of work put into that, a lot of work. And we've been following that program, but once we do that, then you have to go to a third party to get your testing done, and it's very expensive to do that. So those are the things that we are looking at. You'll be asked, because I'll put that in the newsletter that comes out every month. We're looking for volunteers to work on this part. We're already talking and ready to start the third-party testing, but there's other things that have to be done. So that's where we're at this particular point in that process. All right, any questions before we get started about anything? We've already talked about breaks, we've talked about the restrooms, we've talked about those things. So let's look at moderate and procedural sedation for non-anesthesia providers. The reason we say non-anesthesia rather than non-anesthesia nurses is because a lot of dentists and a lot of physicians, even podiatrists, PAs, take the course. Now, but the target is going to be to those of you that are in this room, the RNs. So we're going to talk about your scope of practice and where we go. From my faculty disclosure, which is a part of the ANCC Continuing Education Program, I do own Healthy Visions. Healthy Visions owns Sedation Certification, and I'm also the founder and at this time the CEO and president of the American Association of Moderate Sedation Nurses, and the president of the board. So that's where we're at this particular time. What we know is that you, the nurse, and nursing services, one thing about being a nurse, it's the only profession I know that has two things. Number one is it's the most trusted profession out there, which is amazing. So when you're talking to patients, just your presence makes a whole difference in their demeanor and how things are going to go. The second thing is if you're a nurse, and that's what I liked about being a male nurse, starting off as a pediatric nurse before I moved into anesthesia, is I had 1,000 other directions I could have gone. That's that many paths in being a nurse. You can almost do anything in nursing. Everything from disaster. I also used to teach the biological and radiological warfare class because I am a graduate of the Naval War College. They taught me that stuff. Okay. I can't teach in nursing school, but I can teach. I don't even have a BS in nursing. I'm a diploma nurse. I went to school when you actually had to work. Oh, excuse me, I didn't mean it that way. When that's what you did. I mean, it was like you went by university time. It was a 4-year school, but we went 3. We didn't get any time off during the summer. So that was how I learned and what we did. But we started patient contact the second semester, and we stayed in patient contact for the rest. So we understood a lot of that. Oh, for those of you that are new, you know, patients every night used to get a back rub. Those are the things that used to happen to the patients. Oh, and by the way, too, if you didn't stay 5 days, it wasn't really a hospital stay. So that's why they had to do it. In those days, you had to have footboards because people get foot dropped. They stayed in the hospital so long. Now they walk home. You don't have to worry about that right after they're done, don't they? All right, cool. So let's look at what we want to think about is invasive procedures, therapeutic procedures, psychology nurses. I mean, there is everything that goes on within nursing out there. So you, as a nurse, can be called upon, as some of you have already been having happen to you, called upon to say, go down and do some sedation. Well, I don't know how to do it. Well, you've been taught how to do an IV. You've been taught how to put medicines in IVs. So therefore, just do it. Well, you know what? There's thousands of medications out there, and we can't. I think if any of us really know how to do 5, we're doing good. If we know how to do 10, we're really great. Most of us carry a little pocket reminder around. So, I mean, even in anesthesia, let me go back and make sure I got the right milligram per kilogram for this particular patient. So those are the things we want to look at. Patient monitoring, discharge instructions, family teaching, a big part of what we do. Not so much what other people do, but nursing, you are expected to do family teaching and patient teaching, and that's a part of what we're going to learn. Before you send them home, there's some things they need to know. And yes, Valerie.
That brings up a question I have about pre-operative teaching. Because what I've been finding is that our surgeons, we work with a particular couple of groups of vascular surgeons, and I would walk into my patient's room and start talking to them, and I'd find a lot of anxiety. So I did an informal poll one week, and every single patient I asked, when I asked about what have you been told about, you know, how you're going to be sedated today, they weren't taught anything. They were, oh, it'll be handled.
Yeah.
And so that's one thing moving forward I want to work on, maybe doing some patient teaching pre-op that I can work with the office with to get patients where they're a little more at ease.
At ease. You're going to love this course because the last hour is just on patient communication. It's all about that. So the question was about preoperative teaching, and patients are not being taught preoperative, what to expect, what's going on, because it creates a lot of fear. The unknown is always fearful. And the unknown is even more fearful when your neighbor says, oh my God, that was the worst procedure I've ever had, right? My doctor said I was the worst he's ever seen. So we're going to get into that, and we'll talk about that. So we are going to get into safety concerns. Are all nursing care critical elements of patients undergoing moderate sedation, or we could also call it moderate sedation / analgesia, because you don't just do sedation, give them a little medication there. So let's move forward to Module 1, the scope of practice. And that's what we're going to talk about as far as where you are and what we're doing. Sedation is not nurse-specific. Everybody's involved in it to a degree. So let's talk about who else gives sedations, Christy, in your area besides the nurses?
That's it.
No anesthesia personnel? All right, so she's in an area. If she doesn't do it, there's nobody to call on, right? So you got to make sure you're safe. All right, cool. And sometimes that means what? Being assertive with a physician who wants you to give more than you know you're not ready to give. But you also got to have the experience to what? To know how much to give, how is the patient responding. It's between you and that patient, understanding, and that's what this is going to be about today. How do you know you're safe where you're at? Well, you let the patient tell you. That's what it comes down to. If you can talk to that patient, then guess what? You know they're breathing. If they can talk, they're breathing, and that's the main thing we're talking about right there. Okay. So we know physicians do it. We know dentists do it, because I know that's the biggest ad. Pain-free dentistry. They give you a little pill and bring you in. So half of that is the placebo effect. The other half's just taking the edge off. PAs. We had a lot of PAs that go through this course, which kind of surprised me when we first got started at what they were doing. But they're working with their physicians. A lot of them in either office-based surgeries or same-day surgeries. Podiatrists, another one. They do a lot of this in their offices. And then others as defined by their scope of practice. We have people that will call us and say, can we get certified? Well, all I can say is what we have to have is what does the scope of practice with the license that you have in your state say about what medications you can give? And we go by that. That's all we can go by. Because I know that in some states, dental hygienists can do sedation. So those are the things that we look at. And there's some group that do... I can't even remember the name, it's so long, but I think it has more to do with like running the pumps for like open hearts and places about giving sedation. So we've had a few of those. We have a few that we waiver some of our regulations because they're military, and you have some corpsmen because of where they are and what they do, we allowed them to take it. But they could only utilize it as long as they were still in the Navy. They couldn't use it outside of, quote, that scope of practice. So those are the people that we look at and what we're working with. So, why do people need sedation? Well, you already brought it up, right? They're anxious, they have anxiety, they have fears. They've been told all of these awful things that are going to happen. All the jokes when you go for endoscopy. So there's a lot of things that we're going to talk about. And then on the other side, it's still the kids too. I can remember when sedation for children was called a papoose board, you know? Yeah. So that goes way back. So what we want to do is minimize anxiety and discomfort, thereby avoiding undesirable autonomic responses. What's an autonomic response? That's the fear, the high blood pressure, the increased pulse rate. All of those things autonomic, fear, you know. It's kind of like what you're feeling right after you had a close call in an automobile accident. You know, and that's kind of what they go. They go in thinking of all the worst things that can happen. Well, we want to just go in and say, okay, this is safe. I'll be there to take care of you. And we'll go through all of that language before we finish today. I'll give it to you, right? This is what you say. This is how you say it. This is what you don't say. So that's cool stuff, all right? We want to expedite the procedure. It's hard to work on a moving target. So therefore, you want them laying still. And some surgeons can't handle the talk. I've been told when I was doing sedation on a case, put them to sleep. They're driving me crazy because you give them a little verse, they start talking, man, they're happy. They think they've had 3 or 4 glasses of wine. Make everybody nervous. So give them a little more. All right. And then you want to increase patient satisfaction. Now that's a big deal today, isn't it? Because surgeons, physicians, hospitals are now getting reimbursed on that patient satisfaction survey. You, the nurse, are going to have more to do with that than anybody else. Doctors are doctors. Operating room nurses are operating room nurses, all right? So you, though, as the person with the say, you're the one going to be talking to the patients most. Now, what we're also going to teach you is how do you do a little in-service in your PACU, a little in-service in your operating room, a little in-service that says, if we will just do these few things and do a 10 or 15-minute talk, and talking to our patients this way, we're going to decrease a lot of their anxiety. We're going to make our job easier, okay? So that's the process that we're going to go through. Moving on, let's talk about historically. I got involved in this in the early 1990s, 91 I think it was. I'd just gotten back from Desert Shield, Desert Storm. I was the low man on the totem pole because I had also just checked into this hospital as the new nurse anesthetist, Naval Hospital, Jacksonville, Florida, and they said, Ron, you got to be on this committee. What committee? I'm here to do anesthesia. I'm not here to be on committees. That's the way we anesthesia people think. So they put me on the committee, and it was the new, quote, JACO, now known as Joint Commission, their Committee on Patient Safety for Sedation, because, as you can see here, there's also something else that got started out there, and that was called same-day surgeries. Remember when you used to have to go to the state capitol, get a certificate of need before you can open one? Now they open them about on every corner, so there they are. So in the 1980s was when those started, and then they were looking at taking healthy, low-risk patients and putting them into a more controlled environment. Now, the original same-day surgeries had to be within 3 minutes of a hospital. So, and it couldn't be anything more than ASA2. So you can see everything has an evolutionary effect to it. We can do this, we can do that. If you want to talk about the 50 shades of gray, man, when you start doing ASA things, those grays really start moving in there a lot, all right? 1990s, when I started getting increased ambulatory surgery, increased consumer demand, changes in reimbursement. That was, in the 80s was when the DRGs came out. Insurance determined how long this was going to stay in a hospital. Insurance companies determined how much you could make on every case. It wasn't now by the state, it wasn't by the hospital themselves making their own rates. And it was different for different providers. So, there's a new drug came out in the early 90s, and that drug was responsible for 83 deaths that were documented. I would say for every documented one, there was probably 3 or 4 that wasn't documented. Nobody sent it to the CDC or to the state health to say, hey, this is why this person died. We didn't have root cause analysis in those days. Anybody want to guess what that drug was? You use it every day. Versed, midazolam. So, what happened was, as we get to the drugs, it was about 5 times more potent Valium, but it came in the same package. It came in the same 5 milligrams for cc, for milliliter. So that was a part of it. That was when Joint Commission got involved, and that's when I found myself sitting on this committee to come up with the rules and regulations and training for the people in outside of the anesthesia or surgical department, like dental, plastic surgery, endoscopy, setting up guidelines. And so I ended up being the one doing that. Now, not only did we do that, we had to audit them. So every month I had to go by and pick up their anesthesia records, I had to pick up their narcotic records, and I had to sit down. I mean, that's a big job. I was out to do anesthesia, and I'm sitting here doing paperwork. So those were the things that got me started in this, and I started then putting together a training program. At first it was like an hour, some of what you've had. Let's make sure we know, and it was just about knowing the drug dosages and knowing, hey, you actually do have to document this stuff. You just can't take a blank record back. Yeah, and we do need to do some QA, so if you're dropping your sats, at least let us know you're dropping them. It doesn't mean you did a bad thing. This is kind of normal, because everybody was afraid if they had any kind of a problem, it would go back on their fitness reports and they wouldn't make rank, so that was something. So, what did Joint Commission do? The JACO, they said Anesthesia department is in charge of sedation in every aspect of the hospital. Well, it wasn't. It was me. I was the anesthesia department at that point. So we came up in 1994 looking at a uniform conscious sedation policy that would be applicable across all the sedation areas. Now, that started making some changes too, because there was also another new drug that came out that people started being scared of. Well, at least the ASA, the American Society of Anesthesiologists, and the AANA, American Association of Nurse Anesthetists, were concerned that, well, if we're letting all these nurses out there just go in and start giving sedation, we make these drugs look really easy and safe, and we're afraid they'll start using them. So when we get into, quote, Deparan and propofol, we'll talk about that area and the pros and the cons in both areas, okay? Now, 1998 moderate and deep sedation care standards are incorporated into anesthesia care standards. So a lot of what we talk about today is from the anesthesia side, so we have to read into it depending on what that state is. What can you do within those standards? So if it says anesthesia, think anesthesia/sedation, because that's really what we're talking about. So any questions about that history? That's how I got involved. And when I was at Jacksonville, I put the program together, just a short one. Well, when you're in the Navy, every year or two, they move you. So my next location was in Rhode Island. They hadn't started their policy yet. So I took my policy. I just took it with me. I had it with me. So I took it up there. We incorporated it there. After that, I went to Okno, which was a hospital that was in Oakland, California. I introduced it there. My next job, I'm on about 6 ships between all these different hospitals, though, so, which I put it on the ships. But when I got to Norfolk as the assistant department head and as the chief CRNA, it really became my project now, because we were having some problems at this big hospital because we had some docs that were coming in that had training in ketamine. They wanted to do ketamine. We had GI doctors that had no idea about sedation, but they were wanting to do sedation. So then I took my little short program, we increased a big program, made it a day-long program, or a 4-hour program. Later I made it a day-long. Made it a 4-hour program that everybody that gave sedation did. We made sure that there was at least one nurse on every shift that could be called to the ER or to any other emergency place to give sedation. We had a really good program, and then we had the competency set up for each of those nurses to do that too. And so once I left there, where did I go after that? Then I went to Beaufort as the Director of Patient Services. Then I had power. Director of Patient Services. So we incorporated that program down there. I retired. Now, when I was at Virginia, I was the president of the Virginia Association of Nurse Anesthetists, which means you do what? You get put on kind of the speaking circuit. Well, Ron, come and talk to our state association about what you do with sedation. When I retired, I started getting phone calls. Hey, Ron, that program that you talked about at our state meeting, do you have that? Could we use that to teach our nurses? Sure, I'll send it to you. Well, I'm pretty slow. It took 3 of those phone calls for me to realize I could make some money at it in my retirement days. So I just put together, I thought, well, you know, a 4-hour program's not enough, so we increased it to do HCE, so a full-day program. And we started going to hospitals and doing it, and we, about 2 years later, said, anyway, we can do this online. So I hired a guy, and we've got it online now. Then we said, well, is there any way we can get a certification? Sure, we'll just change it from CE credits to certification. We did that. That's what they do with BLS, you know. And I said, well, don't you have an association? So the next thing I'm talking to the state, and we've got a charter, and we've got an association. So it just kind of evolved through you, the people who had taken the course, and can we get this and can we get that? What I should have said, yes, if you will help me. That would have been the smart move to make. So that's where we were, that's where you are with how this void, because there's still this huge void out there of actual training. Now, any hospital can do what I do. They can do a 1-hour and say, you're certified to give sedation. We'll talk about that when we get to the Joint Commission rules as to who can make that determination. However, some of the larger hospitals that are looking for magnet service, they have to have a certain amount of nurses that have a certification that is through or recognized by the ANCC. So those are the ones that really don't come and work with us. The others, hey, we're happy because when Joint Commission comes in, guess what? They see that we've had over 80 hospitals actually license this program. So when Joint Commission comes in, they see that they've got this program and how it's laid out. Check off. We don't need to look at that when we know how it runs. We've seen it in a lot of other hospitals. So that's the good part. And then the other 3 accrediting bodies aren't the same process with that. So we're proud of that part. So what about moderate or, quote, conscious sedation? What else could we call it? What was the original title? Valerie, you've, back in my day, half of my day, what was the original title?
Well, Twilight Sleep many, many years ago.
Well, that's OB. What else? Remember you said IV conscious sedate. Big long word which became moderate sedation. And we'll talk about why did they change the title. Why did they change how it's called? Because you needed a more specific definition of actually what you were doing. We'll get into that. Okay, so let's just read this. It is a minimally depressed level of consciousness induced by the administration of a pharmacological agent or agents in which the patient retains continuous and independent ability to maintain protective reflexes, a patent airway, and can be aroused by physical or verbal stimulation. What does protective reflexes, what does that talk about? What is protective reflexes? What are they referring to? Say that, Vicki, say again.
Breathing on their own.
Breathing on their own. That's necessary for life. That's true.
Gag reflex.
Gag reflex. The main thing is the gag reflex. Protective reflex. In other words, if you puke, what do you want to do? You don't want to just let it drizzle down into your lungs. You want to cough it back up. You want to gag it back up. So that's the main thing, is that reflex. Continuous, meaning nonstop, and independent. They do it on their own. You don't have to make them do it, all right? So that's the key that we're looking at right there. So let's look at these levels of sedation. Pretty easy to understand. Minimal sedation. Minimal sedation, also for some people it's called being awake or awake sedation. Minimal sedation. Can you think of who would use minimal sedation? We've discussed it already. Dentist or anybody who would give a pill to just take off the edge. I had a person that I consulted with about a month, 6 weeks ago, that had come to Knoxville to have proton therapy, because proton therapy is this one of only 1 or 2 places that actually use it. He had throat cancer, but he couldn't put on the mask to hold him down. I don't know if you know what they do, but he had it here. So they put a mask on, then they bowled it down, and he was claustrophobic. And he just said, no, if I have to do that, then I'm not going to have the treatment. Well, radiation does the same thing, and he was taking chemo. So they were giving him a little Xanax. That wasn't helping. So they sent him to me. And why would you think they'd send him to me? Because I have another talent. I'm also a hypnotherapist. Navy got me started in that. So that's why we're going to talk about that hypnotic language that makes a difference. But they sent him to me. It was like a miracle. He went back and everything went well. All right? So very simple, very easy to do, just changing that perception. But they were giving him Xanax. It did not help. And again, right, dentists give you a little pill. Maybe if you go in and you have to have an MRI or you have to have a CAT scan and people are a little bit claustrophobic, here, take this before you come in. So nothing that has to be monitored, as long as they take one, all right, and they'll do fine. Okay, so minimal sedation. When you take the pill, the response is the airway, the spontaneous ventilation, and the cardiac function should be changed, should stay the same. Now, when I say there shouldn't be any change, what I mean by that is it should, if it's out of kilter, bring it back to normal. Shouldn't change it in the area of, hey, you know, we got to be concerned about too low blood pressure, too low pulse rate, those types of things, or breathing mainly. Let's don't quit breathing. You know what the 3 to 5 rule is, right? Come on, St. Christy, I know you know the 3 to 5 rule. No? All right. 3 to 5 weeks you can go without food without dying. All right? Okay. 3 to 5 days you can go without water without dying. 3 to 5 minutes you can go without air. Maybe not die. That 5 minutes one, that kind of worries me. But, up to 3 minutes, you shouldn't lose too many brain cells. But it's necessary for life. And the point I want to make with that, we don't have a lot of time here. We got to deal with this. So this is pretty self-explanatory. So let's look now. Minimal sedation treatment. Moderate sedation shouldn't be much different. All right? So in moderate sedation, basically what you've done is put them in, quote, we could say that kind of a twilight sleep. Do not use the word sleep, though, when you're working with sedation. Because you're also going to get some, if you haven't already, that said, well, last time I woke up right in the middle of it. Well, yeah, you had sedation. You're supposed to, They were talking to you. All right. So the thing about that, everything should be responses, purposeful. So if they're laying there and it looks like they're snoring or something, and you say, hey, Charlie, how you doing? And Charlie says, I'm doing fine. But now that's not a good question. Why? We're going to talk about how you talk to patients all the way through. To say, Charlie, how you doing? His interpretation may be, okay, something must be wrong. You're right. So you can say, hey, Charlie, take a nice deep breath for me. Charlie, how many kids you got? Well, now be careful with that one because they got this medication on board, and you may only have 2 listed, but he may tell you 3 or 4. All right, so be careful with that one. All right, airway, man, they're there, they're breathing, they're doing good. At the most, if they do a little snoring or something, you just do a little chin lift. That's all you got to do. Spontaneous ventilation means they're taking air in and out. And then cardiovascular function is usually maintained. It may drop a little bit. As long as it stays within that 10% realm, you're okay. But in moderate sedation, it should not go lower than that, as long as when they come in, everything is stable and what it should be also. But geriatrics, it could be different. All right, now we're going to get into the part where we've got to have some concerns, and that is deep sedation and analgesia. First of all, responses, airway, spontaneous ventilation, cardio function could change. The cardiac usually just stays the same. Even in general anesthesia, most of the time it's going to stay the same, even though your chances of it dropping down are going to be higher. But response, purposeful, but it takes energy. In other words, what I mean is you may have to hurt them a little bit, which you don't want to do. Now you're abusing your patient, all right? But I've seen people do that. They'll pinch that earlobe. What are you pinching the earlobe for? They don't have any feeling there. Yeah, they do. No, if they had feeling there, all these women wouldn't have holes in them, So the other thing is if you talk to them, you have to yell at them for them to understand. You've got to get past that break of where they are. So airway, they may slow down a little bit. This is where it's easier for that tongue to fall back, get obstructed. So you've got to be much more vigilant and diligent in what you're doing. And that word vigilant you're going to hear throughout the entire day. So that's the other process we're looking at. Spontaneous, they should be breathing. Even in general anesthesia, they can breathe. So let's look at general anesthesia. How many here are qualified to do general anesthesia? All right. Which also means you're probably not qualified to do what else then? Deep sedation. Because you've always got to be able to do what?
You've got to be able to rescue.
At any level. They used to say one level more. Now it says at any level you've got to be able to rescue. We'll talk about that the next slide. So, intervention often required, frequently inadequate, may be impaired. So those are the things in general anesthesia you've got to be ready to do. There is one place, though, if you're really confident and competent there, that you can almost get out of any problem. Where would that be? Which one of these? Responsiveness, airway, spontaneous ventilation, or cardiovascular function? Which one of those, if you're competently confident, and you can handle that, you can get out of almost any problem. 3 to 5 rule. Airway. If you can handle the airway and you're comfortable with the airway, then you're going to be very safe in doing sedation. Unfortunately, this is not a skills class. We'll talk about it, what you need to do. How many here have ever put in a tracheal tube? Good. That means you've not had to. That's a good thing, all right? How many have ever put in a nasal airway? All right, good. Easy, simple, as long as you don't hit an artery like happened to me one time, and we had to bring in the ENT docs to stop the bleeding. I almost had to give a blood transfusion. That was not a fun day, by the way. So, as we move forward, then let's look at what's next. What's next is moving through the continuum of care. Continuum of care means you start here, everybody's happy. As you move down, people should be happy until they get what? Unhappy. So, moderate sedation can go either way. Awake and minimal sedation, if you're getting ready to do a procedure, you want them to go one direction. That's towards moderate sedation. Once you get into moderate sedation, they can either revert back because you didn't keep up with their medication, which may be okay as long as they're comfortable. But they could start into deep sedation because you're having trouble taking care of their anxiety, you're having trouble taking care of their comfort area, so you give a little more and you give a little more. Next thing you know, you got a lot more in there, and now you're in deep sedation. Now, the thing about deep sedation, you got to keep in your mind, you got 3 ways to go. Get back to moderate, the ideal thing to do. Or you can move over to general if you're very comfortable with taking care of your patients. An airway may not be a problem. However, at this point, there's an arrow that goes downhill. And that area says respiratory and cardiac depression. Depression can turn into what? Arrest. I hate arrest. Whether it's because I ran a red light or whether it's because my patient does bad. Don't like arrest. So those are the things I want you to think about when it comes into that process, all right? Now, in general anesthesia, you got 2 ways to go. You either go back to deep, which will get you back to moderate as you let the medications wear off through their duration of time. Or again, get scared. What happens if you, the provider, get scared about taking care of an airway? You become what? All thumbs. You don't think as fast because anxiety and memory deprivation go together. All of a sudden you can't think. And of course, you become all thumbs, so as soon as you try to get that airway out, that mask, that valve, what happens? It falls apart. And it don't fall on the floor where you can reach down and pick it up. It goes up under the table. Now you're on your hands and knees trying to get it out. You know that. It's happened to you. You know, one thing about it, I've done this long enough because I've been doing anesthesia since 1973. I graduated in 74, then I graduated again in 75. Now, how did that happen? Well, they changed the rules while I was in school. So my school said, well, you came in for 18 months of anesthesia, we're going to let you go. I applied to take the boards, and they said, you hadn't finished. You still got 3 months to do. No. What? I got a job. I'm working. So I had to go back to school. But they were good since it was OJT anyway. I kept my regular job during the day, and then I worked evenings at the school so they could graduate me later. So now we're moving into this process. All you have to do is be vigilant to keep that patient worried. And which one of these continuum of cares?
Keep it moderate sedation.
Moderate sedation. Or be comfortable. You're going to hit some deep sedation, I guarantee you. But deep sedation is not bad. It just means you have to be vigilant and make sure you don't go beyond that. And how do most people get into this area? How do they start moving from moderate into deep?
First of all, I think not really monitoring and tuning into your patient. You just can't watch numbers. You've got to watch the facial expressions. You've got to watch everything. You've got to watch your patient.
Get off of the monitors and get onto the patient. Exactly. I had more trouble teaching that concept when I was teaching student nurse anesthetist. Quit looking up there. Look down here. Look at the surgical site. Do you know what pulse ox used to be when I was in school? Or when I was my first years of anesthesia? Come on, make the incision. I want to see what color the blood is. Serious. So there's been many times I was nervous. Lips didn't look right. I'm giving them 100% oxygen. Okay, I need to see the blood. So those are the things that we did in those days. So you're exactly right. All right, goals of safe sedation. Very simple, very easy. Maintenance of adequate ventilation, homeostasis, and circulation. Everything we just talked about is round up in those 3 words right there. Ventilation, homeostasis, and circulation. So the ABCs. Intravenous line is essential. You cannot do sedation without an interventional line. You can do minimal sedation. Supplemental oxygen is appropriate for most cases. We're going to talk about that a little bit because you don't have to have it with everybody. And there are reasons maybe you don't want to use it with everybody. So we'll talk about that later. Number 2 here, maintenance of appropriate level of consciousness. we want to alter their mood. Well, maybe not. Maybe they're already in a good mood. We want to make it better. We don't want to make them angry. And people get angry if they don't get, they want to be the center of attention. You're sitting there talking to somebody else. They're not the center of attention. We've reverted into our childhood. Pay me attention. I'm paying you to be here. But see, as nurses, sometimes we don't think that. We don't say, they're not the customer. Who's the customer? The insurance company, because they're the ones who pay you. So, and some people think in those terms. Okay, they've got to be able to cooperate, especially if you're doing colonoscopy and you want to tell them to turn over on their side. So those are the things they've got to be able to do. Or squeeze your hand so I can see where we are in a hand surgery maybe. So those are things we're looking at. We would like for them to not remember everything though. Have some degree of amnesia is desirable. I'm going to tell you a story about that. I had a friend. Friend had to go in for a endoscopy for an EGD. He had been complaining of having trouble swallowing for 2 years, but he was also having some gastrointestinal problems, some pressure on his chest. So nobody ever looked in his throat, but every time he went, he said, I'm having trouble swallowing. So he's going for this EGD. He's already done all his cardiac workup. Goes for the EGD. I'm having trouble swallowing. Now, the nurse comes and he's told him too, I'm very sensitive, he says, to Versed. Give me about a quarter of what you would normally give people because he's had it before and he knows what it did to him. Tells the nurse, difficulty swallowing. Tells the doctor, difficulty swallowing. Tells the doctor, tells the nurse, very sensitive to Versed. They take him into the room. I said, what'd they do? Well, I can't remember. All right. Well, they went in, they put the EKG pads on me, which they already had, they just reconnected them. He said, and then they gave me some medication. He said, I asked him, what'd you give him? He says, 2 milligrams of Versed and 50 mics fentanyl. 2 days he lost. He had no idea from the amnesia side of what happened for 2 full days. They still didn't figure out what his throat, why he had trouble swallowing, until a few months later when he finally started spitting up blood and he had throat cancer. 3rd degree throat cancer. So the point I'm trying to make here is, what was the problem? What could have happened? They took somebody who's already complaining about difficulty swallowing, which could be affected by the airway, or could affect the airway. But then also they gave him a drug he was sensitive to which could knock out his respirations, not even looking into his throat. Because I asked, did they look in your throat? No. Not even looking into his throat. So that was a disaster waiting to happen. Luckily, he was lucky. He didn't lose his airway. So that was and then, now he's a nurse. So I said, well, when you went back to your doctor, what'd you talk to him about? So I asked him, how come, did you see why I was having trouble swallowing? He says, well, you had some kind of muscle atresia. He didn't even see that part because it's right at the base of his tongue. He said, well, what did he see? I said, what else did you ask him? I said, how much training do your nurses have for sedation? Oh, they just do a little OJT here. So they could have had a disaster there. All right, enough of that. Minimize autonomic nervous system response. We've already said what that was. We talked about the gag reflex. What are the autonomic nervous system responses? Again, let's review that.
Your heart rate.
Heart rate. Exactly. We want to get the anxiety levels down. More anxiety, the more pain they're going to have. All right, number 3 on this list on slide 16 is promotion of comfort by elevation of pain threshold. Ensuring patient safety. Using the essential components required to conduct safe sedation. What does that mean? The essential components required to conduct safe sedation. We're going to hit those, but can you get an idea of what that might be already? The training, the equipment, the drugs. I mean, let's get everything together. Let's don't start something and say, oh, man, hold on here. I'm giving you Versed, but I got to go back and get my fentanyl. All right? Don't want to do that. We want to have everything. Oh, airway. God, airway. Where did I put those airways? Come up with that. And number 6, understanding the importance of a systematic approach to sedation that promotes safety and efficacy. That's what we're doing here. We're looking at basically a recipe for success. That's what we want you to have. If we follow these guidelines, if we follow this recipe, then when we get that beef stew done, it's going to taste the way it's supposed to taste. This patient's going to do well because we put all the right ingredients or had them available in case we needed them. when you need an airway, it's not time to go rummaging through drawers to see if you can find one that's the right size that you can use. Oh, well, gosh, man, I got some orals, but don't have any nasals, and they're just awake enough. You try to put an oral in, and they puke all over the place. They gag. All right, your role. You're the RN, the registered nurse, the most trusted profession out there, you lucky son of a guns. All right, so what we're looking at now, you have professional organizations that may determine what your role is. SGNA, they have their own guidelines for doing sedation. AANA, guidelines for sedation. American Society of Anesthesiologists, guidelines for sedation. Your Board of Registered Nursing, and that's why you got that handout when we started. What does your board say about what you can do within your scope of practice as a sedation nurse? And that's what we're talking about. What about accrediting agencies? Well, Joint Commission, AAAHC, they have guidelines as to what type of training you should have also. Now, they are very broad spectrum. They do not put you in a position that you have to do 1, 2, 3, 4 through a certain organization. But they will say that you have to have these particular things. Most of them we've actually already talked about to some degree. And what about individual institutions? What is an individual institution? Yeah. One of the things you were supposed to bring me today was what? Your policy within your area. I like those because you'd be surprised how many people we get says, we're just now getting ready to start our program. Do you have any policies that we can use for go-bys? I had one state board of nursing say, well, yeah, we've been working on that. We've been working on our sedation policy for 6 years. I see, that would be maybe a sentence a month. Okay? Let's do this sentence this month, or this paragraph. But the point was they hadn't done anything. They really didn't know where to start. So would it help you if we sent you a go-by? If we sent you a template that all you have to do is fill in your information? Would you do that? I should have said yes for a certain amount of money, but we didn't. Says, yes, we'll send it to you now. So we sent it to them. Because we just wanted something to put on our website so we could say that this state's got something, rather than say, they have no idea what they're doing. Nor do they care. They just want to make sure everybody has their license to work in our state. All right, and that's really all their job is, to make sure that your license meets your state. All right, your institution can also, in some states, determine what medications you give, because the state has no rule. Joint Commission has no rule. All they say is the institution can make the rule. So if you're doing something you think may not be right, you got to check with the state and with Joint Commission, because a lot of these states, man, a lot of these institutions can do some things that are kind of scary. So we have to look at that. And some don't do as much as they could to make the patient safer and happier. So the role of the sedation nurse, the scope of practice includes preoperative nursing assessment. You've got to do that assessment. We already had the discussion that people don't assess the patient, meaning that assessment is a part of that interview, a part of what we're doing according to what they're having done. Intraoperative nursing actions, being able to take care of that patient during, being vigilant, understanding airway, knowing, should I give more medication or should I not? Because too many cases people get into trouble because the patient's moving around a little bit, they think they're in pain, so they give them a pain medication when that's not what they need. They may be moving around because they can't breathe. So you might want to always check the airway first. Never go wrong in checking the airway first. Post-operative monitoring during recovery process, that's another big one. I had one person in here that when they finished up in this room, she stepped over to the next room, and guess who did the recovery? The transporter. Not a licensed transporter, just the transporter. So those are things that are a little bit scary. Follow post-operative discharge criteria. Have your criteria. Make sure that you follow that criteria and that patient goes home with that criteria, which is written and vocal suggestions. So my friend, how do you think he did with his vocal instructions to go home with when he couldn't remember a thing that was happening? Not a whole lot. Does anybody know anybody that's ever died when they've gone home after having a same-day surgery? You want to tell us a little bit about it or not?
It was my my cousin. She's probably in her early 60s, and she had something done to her neck. I can't remember exactly what it was, but she was sitting up at the breakfast table the next morning, and all of a sudden keeled over and died. Her husband was sitting there and watched her. So I think they may have suspected maybe a PE.
Yeah, that's an interesting phrase of words, of killed and died. I like that. Killed over and then died. Wow. Okay. Now, I've had two people. One went home after this was not sedation, it was a general anesthesia, but it was a gallbladder, nobody there with them, and died because they bled out. The other was my cousin, matter of fact, my favorite cousin. And he went home after a knee arthroscopy, and his wife was with him, but she wasn't with him. She was in the living room. He decided to go back and go to bed, take a nap. Well, 2 hours later, when she went to check on him, he was dead. So, obvious from respiratory problems that happened. All right, so you never know. So these instructions we think about, and I've had people report, yeah, we tell them they can't drive, but as soon as they get out of the parking lot, they stop at the stop sign, we see them switch seats, because that husband is not going to let that woman drive him. He figures it's safer to drive himself under the influence. All right? Explain the discharge and then do a follow-up. What's follow-up? Do you do follow-ups on yours?
Yes, we call them next morning.
Call them the next day, right. And what do they do that night? Well, okay, you're at home. If you have an emergency, if you have a problem, call us. Who did they call? Well, you'll have a number before that. You'll have the number. They'll tell you if you have to call 911, but first place you call the exchange, and they'll either connect you to the ER or they'll connect you to whoever the on-call physician is for that night. So I've never seen anybody that didn't have the follow-up process pretty well in hand. Competency. How do we determine what your competency is to do sedation? Most people think, most physicians think, if you're a nurse, you're automatically competent to do. How many different jobs do we say a nurse can do out there? It could be in the thousands, literally. It could be in the thousands. So every time you move to a different job, you've got to create a new set of competencies. You've got to be able to work within that area. Non-LIPs may not independently perform moderate sedation without an LIP present. What's an LIP?
Licensed independent practitioner.
Licensed independent practitioner. And those, then, you will determine by the number one up there is what's permitted by your state law and by their scope of practice according to their training. And then an LIP would be a physician, an LIP would be a certified registered nurse anesthetist, an LIP may be a family practice nurse. In other words, advanced practice nurse may be an LIP. Depends on the state you're in whether or not they're LIPs. So that's the other thing to look at. If state law and institutional policy allow advanced practice nurses to perform moderate sedation, they must meet all the requirements of practice agreements, state law requirements of LIPs. They're actually talking about certified registered nurses in this. There are some states they have to work under supervision. Tennessee, they can run their own program. I know up in Marshtown, there's about 4 CRNAs up there. I got them their job. They're it. They run the company. Is there a doctor's hospital up there? I don't know. Up in Jefferson County, huh? Up in Marshtown.
A doctor's hospital.
Well, there used to be one years ago. That was the name of it, doctors. So anyway, you just haven't been around long enough. All right. So they will also know what the requirements of those are. Again, it goes back to the scope of practice and what your state says or their state says that they can do. All right. The American Nurse Association defines nurse competence as this. Nurse competence is affected by education, experience, and professional development. So, those are the things. We know what experience is, right? We know what education is, right? Well, education goes more than one direction. Because education also depends on education, not just as a nurse, but in that specialty. SGNA, AORN, CCRN, all of those is what we're looking at. CSRN now, Certified Sedation Registered Nurse, which we're working on. All right. So, competency also refers to the potential ability and or capability to function in any given situation. So, within your area, your competency means if you're doing sedation, you should be at least knowledgeable in the processes of how do you intubate, how do you put in oral airway, how do you put in nasal airway, how do you do a head tilt, chin lift. Those are the things that are going to be a part of your competency. A path that can lead to improved competence is certification in a specialty. So right now you are in a newborn specialty. We're trying to get it listed as a nursing specialty, and that's sedation nurse. That's the process that we're working. Every week, basically, I'm talking to somebody. How do we move to this? And they say, well, $50,000 will do this, but then you don't own it anymore. We do. And I said, now why would I pay you that kind of money and then I don't own it anymore? But I have to do all the work anyway. So we're working on it. Okay, the ANA, American Nurse Association, defines certification as a means of measuring competency and the identification of competent nurses that will promote the public welfare of quality in health care. So the key word here is identification and measuring of that competency. So how do we measure it here? Well, you got a whole bunch of stuff that's going on in your book, and we'll go over some of those. And how do you take your test? You're going to take your test online. There's a competency manual in the back that you can, each chapter then has questions, so you can look at that. There's go-bys. How do you set up a competency as a preceptor in your area where you're working? So those are the key processes and things that we'll be looking at in that area.